You are listening to Repetitions with Daisy and Jack. Today we are giving you real, science-backed research with zero ads for supplements. On today's episode, we're breaking down why going under the knife for cosmetic procedures might be a waste of time and money if you haven't first dealt with your body fat. Jaw implants. The forums treat them like the final unlock. Get lean, get the jaw, become the template. The math on that is worse than anyone's posting.
A lot worse. A systematic review published earlier this year pulled 5 decades of facial implant data, and the overall complication rate across the pooled literature is 4.4%. That's not a scare number. It's just the actual number.
And nobody on the forums is quoting that number.
They're quoting before and after photos, which is a different data set entirely.
So let's start with what the Hardmaxxing framework actually claims, because I want to be fair to it before we dismantle it. The argument is, facial structure matters for attractiveness. Jawline is among the highest weighted features. Surgery can change jawline, therefore surgery is a legitimate optimization. And the first part of that is not wrong.
The attractiveness research on lower face structure in male faces is real. The forums didn't fabricate it. Where they overreach is applying group-level effect sizes to individual surgical decisions, and assuming that an AI face rater can tell you whether you, personally, are a surgical candidate. It cannot.
The AI rater thing is worth slowing down on, because that's the new on-ramp. It wasn't always surgery first. You'd hear about mewing, posture work, getting lean. Now there are apps that photograph your face, score your gonial angle against some idealized template, and output a recommendation that looks like clinical guidance.
It has a number after the decimal point, so it must be medicine.
Exactly. And the plastic surgery literature has started documenting this. There was a paper, the Snapchat dysmorphia framing came first. Patients bringing filtered selfies into consultations and asking to look like the filtered version. The AI rater is the algorithmic evolution of that same pattern.
The Snapchat dysmorphia paper is several years old at this point. The AI face rater version is newer, and I want to be precise about the evidence level here. What we have is case reports and clinical expert commentary, not effect size data from controlled studies. The mechanism is plausible. The anecdotal clinical record is substantial. But we don't have a number for how much AI face rater use increases dissatisfaction. That's an important gap.
So the cultural driver is documented, but the magnitude isn't quantified yet.
Correct. And that asymmetry matters. Don't let me quote the complication rates with precision and then imply the expectation distortion effect is equally measured. It isn't.
Okay, let's get into the numbers that are measured. Because the systematic review is interesting. It doesn't just give you a pooled rate. It breaks down by implant type.
This is the actually useful finding. The 4.4% overall rate is a historical average across literature going back to 1970. That sweep includes early solid silicone implants, surgeons with no imaging guidance, and small case series from decades ago. When you stratify by material and approach, the picture changes. Patient-specific implants, custom work built from CT imaging to fit a specific person's anatomy, come in at 1.6% complication rate. Off-the-shelf stock implants come in at 6.5%.
That's a 4-point gap.
For a procedure people are treating as interchangeable. And here's the thing that should actually land for the audience. If you're considering this, the tier you want to be in is the 1.6% tier. The question is whether you can access it. Patient-specific implants require imaging, manufacturing lead time, and they cost more. In medical tourism markets, Turkey, Thailand, South Korea, where a significant portion of this demographic is actually looking, the default is more likely off the shelf. So the 1.6% figure is real, but it is not the number that applies to most of the paths this audience would actually take.
The forums present this as a known, manageable risk. What does complication actually mean in this context?
Infection. Implant migration. The implant shifts from where it was placed. Nerve injury. specifically the mental nerve for chin implants, which exits the mandible bilaterally and can produce numbness or altered sensation in the lower lip and chin. Asymmetry requiring revision. Bone resorption under solid silicone implants. The pressure from a non-porous implant sitting against bone can, over years, cause the underlying mandible to remodel. Radiographically detectable resorption in older silicone literature ranges widely. And then there's revision surgery itself, which carries its own risk profile.
No one is posting the nerve damage outcome.
Survivorship bias is doing a lot of work in forum before and after threads. You see the 1% outcome because that's who posts.
There's also an approach question that most people going into a consultation don't even know exists. The implant can go in through the mouth, transoral, or through a small incision under the chin.
And the approach has real implications. Transoral has no external scar, which is why patients often prefer it aesthetically. But oral flora exposure elevates infection risk substantially. Retrospective series data suggests roughly 2 to 3 times higher infection rate compared to submental. The submental approach leaves a small scar that typically fades significantly, gives the surgeon better direct visualization of the pocket, and carries lower infection risk. I should note, there's no randomized controlled trial comparing the two approaches. The ethical and logistical barriers to randomizing patients to surgical approaches are real. What we have is observational series data.
So you show up to a consultation, you don't ask, and whatever the surgeon prefers is what happens to your face.
That's the default. Asking the question is not aggressive. It's informed consent.
Daisy, I want to push on the 4.4% frame for a second. Because the forum steelman is 4% is low for a life-changing result. That's what I hear.
I'll push back on that framing, and I'll do it from the pharmaceutical trial side. A 4% serious adverse event rate in a non-life-threatening elective indication would end a drug trial. We apply different risk tolerance standards to surgery, and there are arguments for why that's appropriate. It's a values question, not purely a clinical one. But the framing of 4% is nothing only holds if you're not in the 4%. And critically, complication rate and satisfaction rate are not the same number. Some surveys in cosmetic surgery report 70 to 90% satisfaction, even with moderate complication rates, because many complications are managed successfully. But those numbers don't capture the patient who had no clinical complication and is still dissatisfied because the result didn't match the morph they were shown.
That's a separate outcome dimension entirely.
And it's the one least represented in the literature. The pre-surgical digital morph assumes ideal implant placement, zero soft tissue adaptation, no swelling variability. The outcome you see in a render is not a guarantee. It's an optimistic projection. The evidence on expectation mismatch is largely case report level, but the clinical consensus is consistent enough that I'd treat it as a real risk, even without effect size data.
There's something I want to bring in that doesn't get enough airtime in these forum discussions, and it's the body fat question. I'm going to be direct about this because I lived it. When I got actually lean, we're talking 10, 11% body fat, the submental fat pad, the tissue under the jaw and chin, reduces substantially. The mandibular angularity that was there the whole time becomes visible. I had spent months thinking I had a structural deficiency that turned out to be mostly a body composition issue.
And this is worth being precise about. Getting lean is not a substitute for genuine anatomical deficiency. Retrognathia, micrognathia, significant asymmetry, those are real conditions that can require real intervention, sometimes with functional implications. The point isn't that surgery is never warranted. The point is that for a 22-year-old at 18% body fat who's been running his face through an AI rater, the first experiment should cost nothing and involve a caloric deficit. Then reassess.
With a real camera, not a front-facing phone camera at 6 inches.
Yes. Wide-angle lenses at close range distort facial proportions. The nose looks larger. The chin and jaw can appear more recessed than they are in person. This was first clearly documented in the rhinoplasty literature. It applies equally to lower face self-assessment. If your concern substantially disappears when you look in a mirror at arm's length versus a phone camera selfie, the lens was doing most of the work.
I genuinely wonder sometimes if I could just process every selfie for lens distortion correction before it hits the AI rater and eliminate about 60% of these consultations.
I've read enough surgical literature in the last few hours to tell you I could probably run that analysis. The bottleneck would be getting people to believe the output.
One more thing before we land. The BDD piece. The plastic surgery literature puts body dysmorphic disorder prevalence at roughly 7 to 15% in cosmetic surgery populations, versus about 2% in the general population. That's not a small gap.
And standard of care guidelines recommend BDD screening before surgery. The evidence on whether that screening is consistently applied, especially in high-volume elective settings and medical tourism, is thin. The gap between guideline and practice is real, and it's the part I'd want the audience to actually sit with. Not as a moral frame, as a clinical one. If you've been fixated on a specific feature for years, it's affected your relationships and daily function, and a prior procedure didn't resolve it, that pattern warrants a psychology consultation before a surgical one. That's not judgment. That's what the surgical literature itself recommends.
Okay, here's where I'd put someone who's genuinely considering this. First, get to 10 to 12% body fat and reassess with a neutral lens camera at distance. Second, if you're still seeing a problem, consult a board-certified plastic or maxillofacial surgeon with specific facial implant volume. Ask to see their own case portfolio, not stock images. Third, ask what implant type they use and why. The gap between 1.6% and 6.5% is a direct question you can ask in a consultation. Fourth, ask about surgical approach and what the infection and nerve risk trade-offs are. Fifth, be honest with yourself about how long this fixation has been running.
The evidence supports surgery for genuine anatomical deficiency, post-traumatic reconstruction, and significant asymmetry assessed with clinical oversight. It does not support surgery because an algorithm scored your face a 6.2 and rendered a version of you with a different jaw. Those are two different indications, and the outcome data reflects that difference.
The forums show you the procedure. They don't show you the distribution of outcomes. That's the gap this episode closes.
And that's our show. Thanks for joining us on Repetitions. If you liked the podcast, you can show our team some love with 5 stars and a follow. See you next time.
Grab news. Thomas.